Hello, everyone, and good afternoon. I want to thank you all for taking time out this afternoon to listen to the presentation on medical screenings. Hopefully, those that want to attend are present or will be joining us shortly. My name is Julia Simpson. I am a case manager with Advocacy Links and have been with them for the last 7 years. Prior to joining Advocacy Links, I did have a variety of work experiences working in nursing facilities and working with a couple different providers in the Wabash County and Grant County area of Indiana. I do have a bachelor's of social work from Ball State University and then have been a licensed social work for the state of Indiana for the past 2 years and just renewed my license this year. I hope the information that's provided today will be helpful and informative. I'm not covering every possible medical screening that's out there, but I did try to pick those that I felt were pertinent to us as we age and also affects those with disabilities. If you have questions, feel free to type them in the chat box. I will try to answer them throughout the presentation and see if we can make sure you have questions answered that you may have. Why are medical screenings important? They're important because as we, let me go back to a screen. They're important because we all age and we all have to deal with health issues, and especially those with disabilities. We often have providers that are providing that oversight and are good at making sure individuals get an annual physical, eye, and dental exam. But as we age, health issues related to age may sometimes be overlooked or missed, especially for those with disabilities, which is why annual screenings are so important. With aging, people may exhibit a change in health that often I've seen labeled as a behavior, when in fact it may be the person is having difficulty expressing their own health issues or the changes they're feeling or what is bothering them. Some other factors is, the person may have difficulty expressing themselves and are resistant to medical care. We all know that white coat syndrome. Even some of us may be reluctant to get that care that we know we're supposed to get routinely. Throughout today, I will be covering the different areas of cardiovascular disease, glaucoma, macular degeneration, cancer, and diabetes. I will also be looking at if the medical screenings are different for someone with a disability. You may ask, how does one go about getting screenings? You're all aware that with any kind of medical procedure, somebody has to pay for it. So this comes up a lot of, okay, how can we make sure the screenings are covered? And there are a couple providers out there, such as Lifeline Screening and Let's Get Checked, who do offer screenings at a lower cost. Some of it can be done online. However, your doctor is your first line of who you need to go through to get screenings ordered for you. And in researching this presentation, I found that Medicare Part B covers the following screenings: cardiovascular, cervical and vaginal, colorectal, prostate, diabetes, glaucoma, lung cancer, and mammograms. Everybody that hits 65 can apply for Medicare, and some of those individuals with disabilities already have Medicare because of their disability. So this is an option for them to have screenings. And I'm going to apologize right now if I butcher some of the medical terms. I'm going to do the best I can to pronounce them correctly, but I may botch one or two here or there. So Indiana Medicaid can be a resource for coverage of screening, but the doctor may need to state it's medically necessary and a prior authorization approved prior to screening being completed. So it's important that any person that wants the screening needs to check, first of all, with their doctor that it's appropriate, and then needs to look into any of the insurance they may carry and what is needed to make sure that procedure can be paid for. We're going to start with cardiovascular diseases. Heart attack, stroke, and other cardiovascular diseases are America's #1 killer, and that's across male and female. It used to be it was more prominent in males, but it has risen in women. Preventative measures and knowledge are the key. So it's important to know how the blood pressure, our cholesterol, and blood sugar contribute to these diseases. More than 92.1 million American adults live with some form of cardiovascular disease or after effects of a stroke. So being aware of your blood pressure, cholesterol, and blood sugar levels help manage that risk. And an important aspect of lowering the risk, also called coronary artery disease or CAD, is managing your health behaviors and risk factors, which that includes the diet, physical activity, smoking, body mass index, blood pressure, total cholesterol, or blood glucose. Some measurements such as body weight and blood pressure are taken during routine exams and appointments, and some cardiovascular screening tests begin at age 20. And the frequency of follow-up will depend on the level of risk. Cardiovascular screening. Blood pressure is one of the most important screenings because it usually has no symptoms and it cannot be detected without being measured. So we really need to be on top of this. And I think some people tend to think, well, I'm young, I feel good, and they don't seem to think they have to worry about this. But if there's a history in the family, or you're feeling different, it could be high blood pressure. And some of the signs mentioned on the screen are like a severe headache, the blood in urine, nosebleed, blurred or obstructed vision, buzzing noise in ear, confusion and disorientation, dizziness, shortness of breath. Those can all be factors that could be a blood pressure issue. And so it's important to have your blood pressure checked. Below 120/80 is considered good, and if you are at that mark, then you should be checked at least once every 2 years, starting at age 20. If the blood pressure is higher, the doctor may want to check it more often. And what tends to happen as we age is you will see a slight increase in blood pressure, especially if you have some of the other factors related to weight or another medical condition. Some cardiovascular screening that can be done is there's the fasting lipoprotein profile taken every 4 to 6 years, and that's starting at age 20. It's a blood test that measures your total cholesterol, the bad versus the good. It can happen more frequently as far as testing if the provider determines there's an increased risk for heart disease or stroke. But after age 40, your provider will also want to calculate what your 10-year risk of experienced cardiovascular disease or stroke may be. So it's important to keep routine appointments with your doctor, so the doctor can stay on top of what your blood pressure looks like. Another part of cardiovascular screening is the doctor may ask for what's the size of your waist or what's your body weight, and they're looking at the BMI or body mass index. This is another indicator that will help determine if you're at a higher risk for cardiovascular disease. So being obese is a higher risk for a variety of problems: heart, stroke, atrial fibrillation, congestive heart failure, and more. If someone is overweight and has another additional cardiovascular risk factor, then the provider may recommend a blood glucose test. This test measures your hemoglobin A1c levels in the blood to screen for type 2 diabetes. And an A1c level of 6.5% or higher is used to help define possible diabetes. So having that high blood glucose or blood sugar levels is a greater risk of developing insulin resistance or prediabetes and type 2 diabetes. And untreated diabetes can lead to many serious medical problems, including the heart and stroke. And test is recommended every 3 years, especially if there are other risk factors. Now, I will share with you that my A1c level is higher than the 6.5. So I am required to get that checked every 6 months, and I am considered insulin resistant. So my doctor is doing a medication I take to hopefully prevent me from going into that type 2 diabetes category. So screening can happen more frequently if there is higher risk with someone. Other screenings that can be used or ordered by the doctor is an abdominal aortic aneurysm, and that uses an ultrasound to screen for enlargement in the abdominal aorta, and that aorta could rupture if it's enlarged. They recommend a one-time ultrasound screening for men who are 65 and older, or it could be as early as age 55 if there's a family history of the condition. For women 65 or older who have smoked or have a family history, it's also recommended that they have the ultrasound screening. And then a follow-up imaging at 12-month intervals is recommended if the person is found to have an aneurysm of 3.5 centimeters to 4.4 centimeters in diameter. So if there is an enlargement, then you may need to go every 12 months. If you have an enlargement that's between 4.5 centimeters and 5.4 centimeters, then it's going to be recommended that you have follow-up every 6 months with your doctor. Heart rhythm screening or atrial fibrillation uses EKG electrodes on the arms and legs to identify the presence or absence of irregular heartbeat. So that is another screening tool that the doctor can use. Okay, so we've covered some of the heart so far. I don't think there's any questions so far. So I'm going to move into stroke. Stroke occurs when blood supply to the brain is interrupted or reduced, and that means that the brain's deprived and can cause the brain cells to die. Buildup of plaque in the arteries can reduce blood flow. So with the stroke, we want to know what the symptoms are. Sometimes it can happen gradually, but often and more likely there's one or more sudden symptoms that affects the person. And I'm sure you've all heard of the term FAST, and that's a quick and easy way to look at someone and maybe help determine if they need medical attention immediately. Is that looking at the face? You can ask them to smile and see if one side of the face droops. You can ask them to raise their arms, and does one arm drop down? You can ask them to say a short phrase and check for slurred or strange speech. If they're having any of the above issues, then you need to call 911 right away and write down when the symptoms started. So, and up above, I mentioned some, they could be complaining of a severe headache that comes on for no reason, trouble seeing with one or both eyes, or seem to be confused and not understanding others. So those are symptoms of a stroke. It's important. I'm just going to go over some of the facts. As the picture states, 1 in 6 people worldwide will have a stroke in their lifetime, and that's directed at men. For women, it's actually 1 in 5, so it's more prevalent for women. 4 out of 5 stroke victims had no apparent warning signs prior to a stroke. And anyone over 40 who wants to be proactive about his or her health should consider screenings. The National Stroke Association states that the risk of stroke doubles every decade after age 55. So some screenings that can be ordered by your doctor after he and you kind of review your risk factors and family history is the carotid artery screening. That's plaque buildup, so it involves the use of ultrasound to identify if there's buildup of that fatty tissue. We mentioned the EKG earlier. Again, that's to see if there's a irregular heartbeat. And then there's the peripheral arterial disease, PAD for short. And again, that's looking for plaque buildup in the lower extremities. People with PAD are at a higher risk of heart attack or stroke. Okay, moving on. The eyes, we all use it to see, and I think it's important that we do cover some of the eye conditions that develop as we age. And this may be one area that the individuals we serve may struggle in letting you know that there's a change or they're not seeing as well. So it's important to kind of review what does glaucoma entail, what are some screenings that can occur. Because there are more than 3 million Americans living with glaucoma, and an estimated half of them do not know they have the disease. Glaucoma refers to a group of related eye disorders that have a few symptoms in the early stages, but then can result in damage to the optic nerve. There are two main forms of glaucoma. There's open angle, the most common, and then there is the angle closure. Both of these can lead to loss of side vision and eventually to complete blindness. There's some myths about glaucoma that I want to review and just so that you can keep in mind, especially when you're dealing with the individuals you serve. There's a myth that if you have 20/20 vision and no symptoms, you won't develop glaucoma. But the definition of early glaucoma is based on the fact that you do not even know or seem to know you have a problem with your peripheral vision. It's determined by your eye doctor's observation of the appearance of the optic nerve. So even though you will not have the symptoms in early glaucoma untreated, your vision will slowly deteriorate. Another myth is glaucoma only affects the elderly. Yes, the risk of having glaucoma increases as we get older, and most of the open angle glaucoma is age-related, but this eye disease can affect people of all ages, even newborns. Another myth is that it only occurs if you have elevated eye pressure. Elevated eye pressure is a major risk and can be causative of glaucoma, but some people with the elevated eye pressure do not ever develop a glaucoma. Another myth is there is no reason to undergo treatment for glaucoma if there are no symptoms, especially since there is not a cure for the disease. Yes, there is no cure for glaucoma. However, there are medications, lasers, and surgeries to help slow the disease. And the last myth is that glaucoma is inherited, and since no one in the family has glaucoma, I won't get the disease. It is true that certain forms of glaucoma are inherited, and that family history of glaucoma is a risk factor. However, there are many glaucoma patients who are the only ones in their families who are diagnosed with this eye disease. So, recommendation for screening for glaucoma, and this comes from the American Academy of Ophthalmology, and they recommend that all adults with no signs of eye disease or risk factors have a baseline dilated eye exam at age 40. So even if someone hasn't had routine eye exams by age 40, it's even more important that screening occur. And the reason they're saying this is because many early signs of disease and change in vision can start to occur around age 40. And given that glaucoma is symptomless in most cases, is it even more important that family members of patients with glaucoma have their eyes thoroughly examined. Okay, the next eye disease we're going to look at is macular degeneration. Again, it's age-related. It's for short called AMD. It's the leading cause of visual impairment and irreversible vision loss in the United States. For Caucasians older than 40, it is the leading cause of legal blindness. It caused deterioration of the macula, which is the central area of the retina. And that retina is paper thin and at the back of the eye, and that's where the light comes through. So it's light sensitive cells, and it sends a visual signal to the brain. So your sharp, clear, straight ahead vision is processed by that macula. And damage to it results in blind spots, blurred, distorted vision, and often those that have AMD find activity such as driving and reading becoming more difficult when they have this condition. I have personal experience with this with my mother-in-law. As she aged, she did develop macular degeneration, and it did affect her ability to drive. She really enjoyed watching TV, and it started to affect that because it takes the middle vision away from you. And as this graph on the screen shows you, that black spot in the middle is what happens with macular degeneration. And then things around that start to look wavy or distorted. And so that's what it starts to affect the daily functioning skills of a lot of people with this condition. Okay. Continuing with macular degeneration, there's two types. There's dry and wet. A person can have either or both types. The dry can suddenly change into the wet type. The dry can advance and cause central vision loss without changing into the wet. And not everyone with early AMD will develop advanced. And someone with advanced AMD does not experience total blindness, but the loss of central vision can significantly interfere with everyday activities. As I mentioned with my mother-in-law, driving was harder for her, watching TV was harder. Okay, screening of macular degeneration. There are several tests that are out there, and I'm going to go through them. Your ophthalmologist or optometrist will be the one that would perform this and determine which test would be the most appropriate based on your health, your family history, and your own history. One is the autofluorescence. It is photos that study the retina and measure the progression of the atrophy in the patients with advanced dry macular degeneration. What the doctors use is a technique to monitor the retinal pigment, or the RPE, which is the deepest layer of the retina. So they're looking at how that retina is working. The RPE maintain the function of the light sensitive cells in the retina. Those are the cells that allow us to see. And in the dry AMD, the layer of the retina thins, eventually causing the death of light sensitive cells. So that affects our vision. So, and that process is what we call geographic atrophy. And again, it occurs in the advanced stage of dry AMD. Okay. Another test is the dilated eye exam. This is to review the back of the retina. So those that go to the doctor routinely for eye exam, you know, you get your eyes dilated, especially after you hit 40. And it allows the doctor to look at your retina and look for signs of disease and determine if there's optic nerve damage. Another one is after dilating that pupil, the doctor aims a bright beam of light into the eye to check for problems. So they're looking at the nerve layer. Is it lining the back of the eye, and how is it looking? Is it thinning? They're looking at the choroid, which is the thin layer connecting blood vessels and nerves to other parts of the eye. They're looking at the health of that. Blood vessels. They're also looking at the optic disc, which is a a small area in the back of the eye where the optic nerve connects to the retina. So the doctor is looking at all of that as they're shining that bright beam in your eye, which a lot of us don't like, but they call that fundoscopy or ophthalmoscopy, and to check the health of your eye. Another test that we typically do when we go to the eye doctor is a visual acuity test or eye chart test, and that measures your sight from various distances. Another screening tool is a fundus photography, and again, the pupil has to be dilated. The doctor focuses a light through the cornea and pupil and lens, and then they use a customized camera to photograph the back of the eye to look for those disease in the retina, macula, optic nerve. So it helps the doctor measure changes between visits. And I know with my mother-in-law, as she was going through her treatment, they did use this photography to try to help determine what was happening between her different visits. Another one is fluorescein angiography, and if the doctor suspects that there is a wet type of AMD, they can conduct this test to try to determine if there's leakage in the vessels, and they will inject fluorescent dye into the arm and trace through the blood vessels into the eye and see if there's any fluorescent patches that can show leakage in the eye. Okay, another one, as I said, there's a lot of screening tests that can be done for macular degeneration. The optical coherence tomography, OCT, that's non-invasive to get an image of the retina. It produces cross-sectional images of the retina so that the different layers and their thicknesses can be measured. When the doctor suspects advanced dry AMD, this technique can identify regions of the retina that are thinning and show him where there's presence of geographic atrophy, excuse me. And the doctor can also use this test to assess the retina's response to various treatments. And again, this is something that was used with my mother-in-law. She did get treatment, laser treatments, and so they would also use the OCT to see how her retina responded to this. Tanometry, this test measures the pressure inside the eye, so the doctor will give you a numbing eye drop before doing the test. The Amsoil Grid can help detect early signs of disease and also monitor changes. And this Amsoil Grid is what was shown on the first slide. It looks like a graph paper. And so again, the person covers one eye and stares at the black dot in the center of the grid. And if the straight lines in the grid appear wavy or missing, it could be a sign of AMD. The grid's not a substitute for going to a qualified healthcare professional, but I know individuals that are dealing with macular degeneration will use it for at-home monitoring and discuss what they're seeing with their eye professional. Okay, so we've covered eye. Is there any questions so far? Okay, don't hesitate if a question comes to mind to put it in the chat so you don't forget it, and we'll make sure we cover it. We're going to move into cancer. Cancer is a biggie. It affects 1 out of every 3 men or women in their lifetime. Every day, more than 1,500 Americans die from cancer. And there are many forms that can attack any part of the body. It is important that a physical exam occur annually and discussion occurs with the doctor about a cancer screening schedule. Factors that determine the schedule will be the person's age, family medical history, the person's lifestyle, occupation, and daily activity. The slides that we're going to be looking at following this one are guidelines provided by the National Foundation for Cancer Research to assist with detection. Okay, we're going to start with breast cancer. 1 in 8 women will develop breast cancer in their lifetime. and 8 out of 9 of those women diagnosed with breast cancer have no family history. It is the second most common cancer in women after skin, and mammograms can detect breast cancer early, possibly before it has spread. It is more likely to occur as women age. It occurs more often in white women than in black, but black women die from breast cancer more often than white. Breast cancer rarely occurs in men because men usually have a lump that they can feel and get it evaluated. So screening tests are not as likely helpful for a male. I do kind of want to touch upon this. I think there's a tendency as women age to think that this isn't as important, especially if they're not in childbearing years anymore or they're not as sexually active. I think there tends to be a tendency, well, we don't need to worry about this. But breast cancer can hit anybody at any time. And so it's not something we want to overlook just because somebody's aging and it may not seem as relevant. I know another thing I often hear is, but it hurts. And yes, there may be some discomfort as you get the mammogram, but I'd rather go through a little bit of discomfort than having to battle breast cancer because I didn't get my routine screenings and hopefully detect it early. Mammography screening, we're going to cover that. It is the most common screening test for breast cancer. It is an x-ray picture of the breast. It can find tumors that are too small to feel, and it may also find ductal carcinoma in situ, or DCIS, which is abnormal cells that line the breast and can become invasive cancer for some women. Mammography, women age 50, whoops, I'm sorry, let me go back. Women age 50 to 69 who have screening mammograms have a lower chance of dying from breast cancer than women who do not have the screening. Talk to your doctor or other healthcare provider about your risk of breast cancer and whether a screening test is right for you and the benefits and the harms of the screening. Regular high-quality screening and clinical breast exams are the most sensitive ways to screen for breast cancer. And I found this interesting when I was researching this, that regular breast self-exam, or BSE, where you check your own breast for lumps or changes, is not specifically recommended for breast cancer screening. I've always heard you need to do a monthly self-exam, but they're finding that while you are able to do that if you want, it is not the most reliable screening for breast cancer. Okay, moving on. Some screening tests are used only for people who have known risk factors for certain types of cancer. So again, that's up to your doctor. People known to have a higher risk of cancer than others are those who have any of the following: a personal history of cancer, a family history of cancer, certain gene mutations that have been linked to cancer, maybe exposure to cancer-causing agents such as tobacco smoke or workplace chemicals, blood clot that develops for no reason, and older age is, those are all factors. And people who have a high risk of cancer may need to be screened more often or at an earlier age than other people. Okay. So these are the slides what I mentioned earlier where it's talking about the guidelines for the different cancer screenings and how to make sure you're on top of speaking with your doctor about your needs. So from 18 to 20, and a lot of times I think people think when they hit, when they're in their 20s that, oh, I'm okay, I don't need any of this. But you do need a complete health exam for females and males. And this includes a discussion with your healthcare provider about your medical history, your lifestyle history, that you have a thorough physical exam and that blood and urine tests are done. it kind of sets the foundation as you move forward for the doctors to help you know what changes may be occurring as you age. Between 18 and 20, they also recommend that you give yourself a self skin exam. Your skin is your first line of defense against disease, and how you take care of it is important. So they do recommend that monthly you're looking at your skin and reviewing the health of it. So this is also important for those of us who work with people with disabilities that may have difficulty doing that self-exam. And if we're giving them direct care, then it may fall to us to help them assess the health of their skin. When you between the ages of 21 to 39, it's recommended that every 3 years that you get a complete health exam, that women get a clinical breast exam and have a pap test. For males, that you have that health exam, that annual health exam. Also, yearly, it's recommended for people 21 to 39 to have an endometrial biopsy at age 35 for someone at higher risk. So again, if you're at higher risk for that, you need to have a biopsy at age 35 just to assess that. Okay. Continuing with 21 to 39, again, they recommend that self-skin exam and then add the breast self-exam, and for males to add that you're checking your testes. When we hit 40, between 40 to 49, every 5 to 10 years, they're looking at, it might be good to get a colonoscopy or a CT colonography or flexosigmoidoscopy. Hopefully I said those halfway right. Anyway, this again would be a discussion with the doctor. I know people complain about the prep for a colonoscopy, but again, prevention is the key to keeping yourself healthy, and that's why we have these guidelines. For someone 40 to 49, every 3 years, again, you want that complete health exam, a pap test, and now they're starting to add a multi-targeted stool DNA test as a possibility. For men, they're adding a prostate specific antigen blood test to the medical screening. During this age, yearly, again, you want your clinical breast exam, mammogram, digital rectal exam, biopsy if you're at a higher risk, and then they're adding a fecal occult blood test or a fecal immunochemical test. And most, again, men also need that fecal test done. And again, between 40 and 49, you're going to continue with your monthly skin exams and checking your breast and testes. Okay, moving on. Between 50 and 65, every 5 to 10 years, and again, this is based upon your history. You may have things done more often if your doctor sees there's an issue, but they want that colonoscopy. Also, they're looking at HPV and a pap co-test for women. For men, it's the colonoscopy. Every 3 years for women, they still want a pap test. The DNA for men, the DNA test yearly still is that annual exam, getting all your mammogram, all that that was mentioned before, and monthly to continue with reviewing your body's skin health and that. So, and I think when this is the age group that I think a lot of times doctors start, and this is just my opinion, start not necessarily thinking that some of these are still as important. But I was at a meeting with one of my older consumers recently, and I asked about some of these screenings, and she was no longer getting a pap test and that. And I mentioned, well, it still is pertinent. And one of her staff mentioned, yes, one of my relatives developed cervical cancer at the age of 80. So it can happen, and that's why these tests are so vital to continue doing. Okay, we're going to move on. 66 plus, again, every 5 to 10 years, if your doctor doesn't say you need them more often, is the colonoscopy. Every 3 years is the multi-targeted DNA test. Every year, they still want that annual exam with your doctor and the mammogram and reviewing all that, prostate exam for the males. And again, that you continue to check yourself monthly and make sure there's no changes that you need to discuss with your doctor. Okay, before we move into diabetes, just making sure there's no questions. Okay. Diabetes is a group of metabolic diseases characterized by hyperglycemic resulting from defects in insulin secretion, insulin action, or both. Type 2 diabetes is the most common form. It's often asymptomatic in its early stages and can go diagnosed for many years. And if you have undiagnosed type 2 diabetes, you're at a higher risk for stroke, coronary artery disease, peripheral vascular disease than the non-diabetic population. The risk of developing type 2 diabetes increases with age, obesity, and lack of physical activity. It's most common in individuals with a family history and in members of certain racial ethnic groups. So African Americans, Hispanic Americans, Native Americans, Asian Americans, and Pacific Islanders can be at a higher risk. Symptoms of diabetes. I think it's important to know this, especially so you can recognize it in yourself, or if one of your individuals you're working with starts to develop some of this, then you may need to help them get screened. Fatigue. Feeling tired is a most common early sign of high blood sugar. However, we also need to remember that our blood sugar fluctuates depending on what we consume throughout the day. We've all heard of, a sugar rush and a sugar crash, and so those can happen through the day, but it can be one of the signs of high blood sugar. Frequent urination. If there's too much sugar in the blood, the kidneys want to get that out, get rid of it. And so as they're getting rid of that sugar, they're going to pull water out with it. So people feel like they got to go to the bathroom more. Because of that, there's an increased thirst that happens. So as we're urinating more, then the body becomes dehydrated. So we want to replenish that. So there's increased thirst. Headaches, dehydration can cause a headache. Of course, a headache can be a sign of different things, but it's worth getting checked out if it's something new or it's with other symptoms that you're getting the headaches. Blurred vision, when there's excess sugar in the blood, it can affect some unexpected areas in your eyes. Nausea, vomiting, and confusion. These are all signs of a rare and life-threatening state called diabetic ketosis, DKH for short. It can have the same symptoms that I mentioned above, as well as people having pain, trouble breathing, dry or flushed skin, fruity smelling breath, or difficulty paying attention. And if you suspect this, the person needs medical attention immediately. Recurrent infections can be a sign of possible diabetes. Elevated blood sugars can weaken the body's immune system, and it makes it harder for the body to fight off infections, making sores harder to heal, impairing, the circulatory system. And so it's important to keep an eye on that. Dental issues. Glucose is present in our saliva as well as blood. So when there's too much of it, it can cause harmful bacteria in the mouth to grow. And with food particles, create plaque. So that leads to cavities, gingivitis, gum disease, and bad breath. So swollen, tender, and bleeding gums are one of the signs to look out for of possible diabetes. tingling hands and feet. Over the years, having too much blood glucose, or I should say having too much glucose in the blood can impair nerve function and eventually cause nerve damage, causing neuropathy. And most of the time, the neuropathy affects the extremities, hands, feet, arms, legs. So we have tingling, numbness, or burning in those areas. Diabetes screening. Based on expert opinion, evaluation should be considered by healthcare provider at 3-year intervals beginning at age 45. Testing should be considered at a younger age or carried out more frequently if individuals have one or more of the risk factors, which means family history, obesity, inactivity, hypertension, race, and HDL cholesterol. The American Diabetes Association recommends testing for prediabetes and risk for future diabetes, again, at the age of 45. If tests are normal, it is reasonable to repeat every 3 years. Okay, so some of the screening tests, the best one for testing diabetes is the fasting plasma glucose, or FPG. The FPG test and the oral glucose tolerance test are both suitable tests. However, the FPG test is preferred in clinical settings because it's easier and faster to perform, more convenient and acceptable to patients, and less expensive. The A1c test that we hear a lot about is a valuable tool for monitoring glycemia, but is currently not recommended for the screening or diagnosis of diabetes. Pencil and paper tests, such as the American Diabetes Association risk test, may be good for educational purposes, but does not perform well as a standalone test. And then the capillary blood glucose testing using a blood glucose monitor or meter can also be used, but it's imprecise, so it's better used for self-monitoring rather than a screening tool. So those are the tools that the glucometer that people will use to test in their homes, just to self-monitor, but it's not a good tool for screening for diabetes. Okay, so that's what I have on diabetes. We're going to move into people with disabilities. So I want to make sure there was no questions. Okay, I don't see anybody furiously typing. All right, so we're going to focus on people with disabilities, and if the screenings and areas that we talked about before affects them differently. And according to the U.S. Census Bureau, there are nearly 50 million Americans who have some type of disability. This was back in 2000. I'm sure that number's higher now. But within that population, persons with disabilities do not receive enough preventative care and receive little or no health screening for such thing as breast cancer or preventive dental care. And that is from the Department of Health and Human Services. In 2003, Centers for Disease Control indicated that among women over the age of 40, only 65% said they received mammography services, as compared to 71% of people, or excuse me, of women without disabilities. People with disabilities have higher cholesterol and blood pressure rates, along with higher rates of obesity. 2002 data showed that 19% of adults with disabilities had higher cholesterol compared to the 17% of adults without disabilities. 30% of adults with disabilities were reported to have higher blood pressure in 2000 compared to 29% of adults without a disability. People with disabilities also have a much higher rate of obesity compared with people without. 42% of people with disabilities were reported as being obese in 2002 compared to 28% of adults without disabilities. It was also noted that there is a trend where women with disabilities tend to be denied reproductive and other health care. People with disabilities should make a point to have their personal physician aware of the need for preventative health screening. And that comes from Rehabilitation Research and Training Center on Aging with a Disability. This is recommended above getting just the regular pit stop exam from the physician, which usually just consists of a cholesterol screening and blood pressure check. So people with disabilities need to advocate for themselves, and us as advocates on their behalf need to help them to speak for them regarding what their medical needs are, and to help make sure they get the screenings that are afforded to those without a disability. So someone with a disability has to make it a point to be concerned about their health as much as they're able. And if they're not able, then, you know, a guardian, a healthcare rep, or a case manager, or, you know, an involved family member needs to help with that process. In addition, they need to be aware and concerned about the specific risks that may be, associated with their disability. And so the following slides are healthcare screening recommendations that are reviewed and followed by everyone, whether they have a disability or not. So these are for both female and male, and their screenings recommended for someone with a disability. Again, self-skin checks. That's no different than the general, you know, individual without a disability. Everybody should be checking their skin, especially if they are sensation impaired and may not recognize if they've injured themselves or have an open area on their body. Monthly, there should be breast self-exams, testes self-exam for the male. A yearly checkup with the primary care provider. And, you know, as it mentioned, it needs to be more than just that pit stop. Oh, you know, I checked your ears, your throat, your heart, your lungs, and you got some blood tests done. Oh, we're good. There should be, you know, a good discussion on what is the person's age. What are some changes that have happened over the last year? Whether that's lifestyle, whether that's activity level, diet changes, those should all be discussed yearly with the doctor. Also, what should be discussed with the doctor, you know, weight changes, blood pressure should be checked. After age 40, a clinical breast exam should be happening sooner if the person cannot do their own exam. Mammography beginning at age 40 to 50. And they mentioned there should be a baseline mammogram done between 30 to 40 or 40 to 50. So there should be a baseline, so there's something to reference back to see if there's changes as a person ages. Yearly, they're recommending a digital rectal exam after age 40. Should be checking for blood in the stool or feces after age 50. Again, we want to make sure there's no colon polyps that can become cancer or colon cancer. Yearly for a male, there should be a digital prostate exam and PSA after age 50 and every 2 to 3 years prior to age 50. And I think a lot of times, at least from my experience with the males in my family, this is not something they enjoy and they tend to put off. So it's real important that they're aware they're putting themselves at risk. Yearly, there should be a flu shot if there's a pulmonary impairment. That's more important. There also should be a complete blood count with biochemistry study and cardiac risk assessment after age 40. So this should be all done at that annual exam. Again, yearly urological assessment, especially if there is impairment. Assess equipment and posture. There should be a functional assessment. How well are they still doing with transfers, with bed mobility and locomotion, whether it's via wheelchair or walking, and a full skin evaluation should be done by the doctor also. So a lot of these screenings so far are not different than what is being recommended for the population without a disability. Every 5 years, there should be lung capacity should be assessed, especially if there is a pulmonary impairment, a lipid panel. We're looking for cholesterol in the blood, eye evaluation after age 40. Every 5 years, there should be the colonoscopy after age 50. Should be motor and sensory testing. There should be changes of, or excuse me, review of changes in the life situation, including coping, adjustment. Are they satisfied with their life? And then we have every 10 years, we have a tetanus booster and a pneumonia vaccine, especially if there's a pulmonary impairment. So these are the sources I used to research this presentation. Obviously, I have not covered every medical screening out there. I tried to focus on ones I felt were pertinent as we age, and also to try to show that someone with a disability needs the same screenings as they age to help make sure we're being preventative instead of having to deal with someone having leukemia, or, could there have been a screening done to prevent them to, not have stage 4 cancer before we realize it? And then we're dealing with trying to make their life as comfortable as possible and hospice care and that. So that was the part of the reasoning to provide this presentation. I'm going to open it up for questions. So feel free to put questions in the chat box and I will answer them best I can. Carrie, are you seeing any questions on your end?
I see one that just popped up. It says, is there in your studies have shown that older consumers lose their ability for walking and feelings in their hands?
I mean, I would say that there's that potential, especially if they have some, health history going on with potential diabetes, or, another condition, cardiovascular disease. Those can all affect how somebody's feeling. But we also need to remember as we age, we tend not to be as active. And so that could lead to somebody feeling, that they don't have as much strength in their hands, arms, legs, which can affect their mobility. And that's why, we talk about physical therapy, occupational therapy being helpful tools to help somebody regain some of that, and, looking at their lifestyle and their activity level. I hope that answered the question.
All the other feedback is that you did a great job, good information, well-constructed presentation, but I don't see any other questions.
Okay, well, I appreciate those positive feedback, everybody. And you never know when you put something like this together how well it's going to go, so I appreciate that. So,
a
yes.
person did respond to your question. It says, no diabetes, but recently lost their ability to walk and cannot use their hands. We have tried to have physician to get PT and OT, but this keeps on being put off.
Okay. And that's where, as I mentioned before, someone needs to advocate on behalf of that person. I don't know how old we're talking, but that would concern me if suddenly they lost those ability and they don't have diabetes or something. There's got to be something going on. And so that's when you really sometimes have to be a pest with the doctor or go to a different doctor if you're not getting any response, and push that, hey, we need to medically figure out what's going on. And that's one thing when somebody starts talking about someone that I have that's older and they're doing something different and they start questioning whether it's behaviors, I say, well, let's look at the medical first. Let's rule out that there isn't something medically that's causing that shift. And if that's ruled out, then we can look at, whether that's a behavioral situation. So I hope that helps. Let's see. Let's say, are we about at 4 o'clock, Carrie?
Yep, 3:59.
Yeah, I don't want to keep.
We started at 2:59, so.
Okay, so we're right there. So I don't want to cut anybody off if they have a question.
I'm not seeing any others. And the person said, yes, this did help. Thank you.
Okay, great.
And that's all that I'm seeing.
Okay, all right. Well, I appreciate everybody's time. Have a great rest of the afternoon. Thank you.
Thank you.
All right. So, Carrie, you'll be the one to have to shut it down.
Yes, doing now.
All right. Okay. Did you have any comments you wanted to make, Carrie?
Oh, I think you did a great job. You did really good.
All right.
So,
Thanks.
good job. And
All
thank
right.
you for doing it.
Oh, no problem. All right. We'll talk to you later.
Okay.
Bye.
Bye.